So I just want to go through some of the pathologies. So for retinal detachment. So here's a video of retinal detachment. Basically, that's a separation of the two layers of the retina, which, as you guys know, is very concerning because it can cause blindness if untreated. So in this, you're going to see a thick hyperechoic undulating membrane floating in the vitreous chamber in the posterior lateral region of the globe. Generally, this is going to remain anchored to the optic disc, and it's going to move with eye movements. If it's small, make sure you see all the axes to ensure that you've actually seen it. And if it's large, so a total retinal detachment, you might see a folded surface attached to the ora surrounding anteriorly and the optic nerve posteriorly. And you also might see vitreous hemorrhages with this, or you might not. So, optic nerve, and then you can see this thick hyperechoic line with the eye moving, that's moving and floating within the eye. You can't see very well in this picture how it's attached, but I'll show you in the next video. So here again, this is the retina lifting off, thick, hyperechoic, free floating, or floating, but it's still attached to the optic nerve in the back. And when you see the retina or the optic nerve come in, you can see how right there, so that's how you can help differentiate a retinal detachment. Any questions about that? No? Perfect. So important to have normal to low gain for your retinal detachments. If your gain is too high, you might not see them as well. And so you're going to pick them up best when your gain is low. Of note, there can be artifacts that you just see within the eye, in the vitreous chamber, that might be bright and echogenic. If you move the eye and they disappear, these are generally normal, but always take your clinical context into consideration. So in terms of retinal detachments, here's some of the literature. This is actually probably the most robust in terms of point of care ultrasound. Because there is a meta-analysis, I'm not going to go through all the papers. I'm just going to mostly talk about the meta-analysis and the case report because it's a pediatric case report. So in Annals of Emergency Medicine in 2015, they did a meta-analysis about the diagnostic accuracy of emergency department ocular ultrasound for retinal detachment. They included 3 trials that all seemed to have low risk for bias. They were all small prospective trials, and they were all adult trials. They had overall patients, and they basically had clinician perform bedside ultrasound using the high-frequency linear probe, so the 7.5 or the 10 megahertz. 2 trials had patients with retinal detachment from trauma, and the prevalence of retinal detachment was anywhere from 15 to 38%. Overall sensitivity ranged quite high, so 97 to 100%. Specificity ranged from 83 to 100, so still fairly robust. The gold standard was either exam by ophthalmology, and 1 trial also included orbital CTs. So overall, they felt the POCUS was highly accurate, so sensitive and specific for retina. But they thought that larger studies were needed, especially in pediatrics. In terms of the study in 2016 by Gabe, this is actually from our center with some of our colleagues. It was inside Peds Emerge Care. They basically had a 16-year-old girl who had acute vision loss with a visual exam that was fairly unremarkable. VA was 20 on 40 and 20 on 60. And the only other positive finding on her exam was spinal paraspinal tenderness. POCUS was able to see thickening of the choroid with overlying partially detached portions of the retina. So they thought bilateral retinal detachment. Optho thought this was acute bilateral posterior uveitis with multifocal choroiditis. And the ultimate diagnosis after multiple tests and multiple specialties seeing her was, pardon my pronunciation, Voigt-Koehane Herdara disease. So let's move on to posterior vitreous detachment. So this is one of your, in your differential when you see anechoic things in the back of the posterior chamber. So it can be challenging to differentiate from retinal detachment. And of note, because this is not my image, I have taken this from LIM in 2014. So in this one, you're going to see thin, linear, granular appearing echodensities within the vitreous chamber. In terms of posterior vitreous detachment versus retinal detachment, so some of the things that can help you figure out which one's which. So they're going to occur for the PVD, going to occur in front of the optic disc. It does not remain anchored to the optic disc. So it's going to be loosely adherent and it's going to be free floating within the eye, especially when you have the kinetic echography. You might be calling this a swaying seaweed appearance. Have that thick hyperechogenic membrane that you see with retinal detachment. It's less intensely hyperechoic, and there may or may not be a V shape associated. So in this video, they do a good job of showing you what's going on. So anterior chamber, posterior chamber, and you can see there's all this debris within the posterior chamber. So it's quite thin. Here's your optic nerve. And basically, if you were to slow this down, it does not attach to the optic nerve. So you just see it free floating like seaweed within the eye. Any questions?
We can debate now about this, like another hyper. Maybe looks like it's coming from, you know?
So it's hard because you're not like in that video, and they didn't describe this case, so I can't tell you exactly what this kid had or this person had, but it doesn't seem like it's, if you look, it doesn't seem like it's attached to the back, which in the retinal detachment videos, you can obviously see it coming back and attaching. And if you're not sure, then then get ophthalmology, because this doesn't have to be seen like immediately by ophthalmology versus retinal detachment needs to be seen quite urgently.
But my understanding was that vitreous hemorrhage wouldn't be attached and would move around. Vitreous detachment would still be attached.
So vitreous detachment isn't attached.
Okay. So then how do you make the difference between vitreous detachment and vitreous hemorrhage?
They look a little bit different. So this is more like these linear, thin, hyperechoic lines. And then we're going to go through hemorrhage in a second. And you can see it's more of like more like doesn't really have a shape. It might just be like a echotexture throughout. There's not like a linear line for it. Okay. And you might see both. It's often common to see both of those things together. So you might have a bit of either of them. So any vitreous pathology, you need to have high gain. So high gain for to better visualize the vitreous detachment. Okay, vitreous hemorrhage is moving on to exactly what you're asking about. So this is more of a diffuse, mobile, echogenic opacity. There can be some hyperechoic strands within, but not as hyperechoic as the others. And these are going to be within the vitreous chamber. They're not tethered by the retina. They float in the vitreous body and then move with eye movement. Some papers have just described them as the appearance of clothes tumbling in the washing machine, so the washing machine sign. Other places have described them as a snow globe. If they're early or they're mild, you might see small dots or linear areas of low reflective mobile echogenicities throughout the vitreous. If they're large or severe, you're going to see blood organizers and forming membranes. And they may actually layer inferiorly if they've been there for a long time in terms of gravity. So when you see a vitreous hemorrhage, like I said, there might be other pathology there. So look for your retinal detachments, look for your posterior vitreous detachment as well. So this is the other points I wanted to make about gain. So you can see here, it's really hard to see anything, but maybe there's a little something that's abnormal sitting on the side. The gain is a little lower here, so only at 70. When you increase your gain, so here's up to 85, you can see the vitreous hemorrhage a lot better. That's just to demonstrate the importance of increasing your gain to look for vitreous hemorrhages. So high gain for vitreous hemorrhage.